Good morning, everybody. Well, it is morning when I'm actually recording this, and I don't have my camera on because I took my son to school a little bit ago. My wife and daughter are now gone, and now it's just me and the cats. And I have pretty bad hat slash bed head, so you guys don't get to see my spectacular looking hair this morning. So anyway, let's talk about blood pressure. Now we just finished in the last video talking about cardiac output, the volume of blood pumped out by the heart per minute. And so now we need to talk about something, again, that's a pretty important healthcare concern for many people, not just in America, but around the world. So with pressure, again, when you simply define it, pressure is the force per unit area exerted on the wall of a blood vessel by the blood. So when the blood is physically in a blood vessel and it's pushing against the walls of a blood vessel, that is blood pressure. Okay. So pressure in general, again, is just the force exerted against the walls of a container by a substance. And so blood pressure, again, when we define it, is the force that the blood is pushing against the walls of a blood vessel with. And we typically express it in millimeters of mercury. And whenever we actually measure it, whenever you go to the doctor's office and they take your blood pressure, we're indirectly measuring the actual pressure of the walls against the aorta as the blood from the left ventricle is forced into it. And so that pressure, again, exerted against the walls of the aorta by the blood coming from the left ventricle, is directly related to the force with which the left ventricle is actually pumping the blood out. So that's what we would measure again as blood pressure. And specifically, like we'll get to, that is the systolic pressure. Okay. So blood pressure is a pretty serious issue, and we actually need blood pressure. So I don't want you to have the impression that blood pressure is bad, because like we're gonna talk about in the next unit with the kidney material, a kidney function actually needs cardiac function. Kidney function needs pressure. And so it's obviously super important for us to have some degree of blood pressure. But when it's too high or too low, that's when it becomes a problem. And blood pressure is typically greatest right out of the heart. And the further away we go from the heart, it starts to decline. So when you take a look at something like this, okay, we've got blood pressure is the highest right here. Diastolic pressure, this bottom number, is the pressure against the aortic walls that remains after the blood has moved through it. And that's the actual pressure, the back pressure against the walls of the aortic valve. The amount of pressure on the other side of the heart, the back pressure against the walls of the pulmonary valve in the pulmonary trunk, is much less. So whenever we talk about blood pressure, it's typically referring to pressure in the aorta. And so as you can see here, as blood moves away from the heart, we go the aorta, and some of the larger arteries right around the heart are called elastic arteries because they have more elastic tissue in them. And then we go away from the heart, and some of the larger arteries that start to move away from the heart are called muscular arteries because they'll have a higher percentage of smooth muscle in them for the body to control where blood flow goes. So most of our key arteries that go to specific organs are of that nature. And then we start to get smaller. We're moving away from the heart. We're moving through circulation. We get down into the arterioles that are feeding into capillary beds. And as you can see, we start to get less and less in terms of pressure. That's actually important because when you start getting down into the arterioles, and especially when you get to the capillaries, if you remember from anatomy, capillaries are only one cell layer thick. They only have one tunic, specifically called the tunica intima, which is generally simple squamous epithelium, and which is very thin, and we don't want a lot of pressure in that because that tissue is already fragile. So the blood moves to the capillary beds on out through the venous side of circulation into the venules, then it starts moving into the veins, and then ultimately back up to the vena cava to empty into the right atrium. And as you can see, the closer we get to the heart in the venous system, pressure starts to become very, very minimal. And so, we have to ask the question, well, if pressure is that low, on its way back to the heart, how does blood actually get back to the heart? Well, that's something that we're actually going to get to. But I wanted to show you this picture because, again, it shows how pressure changes through systemic circulation. And again, its pressure is highest right around the heart. Okay? Now, specific pressures for us. Okay, really, there's three that I would typically want my students to remember: systolic and diastolic pressure, and what's called MAP, or mean arterial pressure. So systolic and diastolic are right here. Okay, and I already mentioned systolic pressure. That's the pressure exerted against the aorta when the left ventricle contracts. Okay, and then diastolic pressure is that residual pressure that is there against the aortic walls after the blood has passed through. And so technically, when the heart is at rest, that pressure in the aorta is the diastolic pressure, that pressure against the aortic valve. Now, a pulse, what we feel as a pulse is the throbbing of the arteries due to that pressure wave driving blood through circulation. That's what we can feel under the skin. Okay, now, so systolic pressure and diastolic pressure, and then this guy, MAP. Now, don't worry, I'm not going to actually have you guys calculate what MAP is, but MAP is essentially the pressure that is propelling blood to our tissues. Now, it's not going to be as high as it is in it's not going to be as low as it is in capillary beds, but MAP is to calculate it, it's a kind of a direct relationship between systolic and diastolic pressure. Don't worry about what pulse pressure is. I don't ever talk about that anymore. But again, what I want you to focus in on is MAP is related to our overall pressure, okay? And as our blood pressure changes, MAP will change accordingly or directly. So if normal blood pressure is about 120 over 80, okay, MAP is roughly 93 millimeters of mercury. If your blood pressure goes up to, let's say, 160 over 110, MAP will obviously be higher. If your pressure drops to 90 over 50, MAP drops as well. So MAP changes directly with our blood pressure. And if MAP is too high, that's going to have a trickle-down effect, a negative effect at the capillary level, and perhaps damage them. If our blood pressure drops too low, MAP will also drop. And if pressure is too low, the body has a compromised ability to deliver blood to tissues, which again is kind of what MAP is. Okay, so again, just keep in mind the importance of both systolic and diastolic pressure and the importance of MAP. Okay, and I always like to tell students MAP is, mean arterial pressure. It's kind of that pressure propelling blood to tissues. It's not some magical singing map that a sweet little girl carries around in a purple backpack. If you know what I'm talking about, you watched Dora the Explorer as a kid. Now, the only reason I know that for sure is when my daughter was young, she was obsessed with Dora, and I watched way too much Dora the Explorer with my daughter. So anyway, MAP, mean arterial pressure. Okay, now, in lab, one of the things that we're going to do in lab, one of our cardiac labs, is we're actually going to learn how to measure blood pressure manually. But also we're going to learn how to take pulse checks. And the reason we want to be able to do both of these, to measure blood pressure and monitor pulses, like it says here in this point right here, we want to monitor the efficiency of the circulatory system. So how effective is our heart being at propelling blood through our body to our tissues? And so blood pressure and a pulse are going to actually help determine that. So your typical vital signs, whenever if you work in a healthcare setting and they say, go check that patient's vitals, you're basically going to get a blood pressure, a heart rate, and possibly a respiratory rate. Okay, but a BP and a heart rate, pretty much the two big ones. Now, with pulses, there's multiple sites that you can take a pulse. Upper and lower extremity. So you can take a carotid pulse in the neck. That's the common one that you often see in movies and television. When a bad guy gets shot, and then the cop will come over and check their pulse in the neck, and they're like, "Oh crap, we needed to question him," kind of a thing. That's the one they usually check it wrong. The brachial artery right here in the elbow area, okay, is generally the artery that is used whenever you're actually taking a blood pressure. And you can take a pulse with the brachial artery, but it's a little bit more difficult in adults and in adults and some small children because of arm mass. But infants and smaller children, I would say, who aren't as large, you might have a better time doing that. Probably the easiest upper extremity pulse to check is the radial artery right here in the wrist. Of course, you can take lower extremity pulses, like the femoral artery runs right down through the groin area right here. And that's not generally one that we would probably check in a lab setting because of it being close to the genitals. So obviously, we're not going to do that. The popliteal pulse behind the knee is also an option, but again, one that we typically don't get because none of us are skilled and do that on a regular basis. The posterior tibial artery here on the posterior aspect of the medial side of the ankle, generally a tough one as well. Probably the easiest of the lower extremity pulses is right here, using the dorsalis pedis artery on the top of the foot. You palpate between the first and second metatarsals. And so again, whenever we do this lab, we're going to use the radial artery for an upper extremity pulse and the dorsalis pedis artery in the lower extremity. Now, important to do both because if you're a doctor, and let's say, I still remember my doctor that I had growing up, and I'm a big fan of getting annual physicals, especially if you have family histories of heart disease. He would check my radial pulse, and then he would check my dorsalis pedis pulse. And I remember one time asking, "Why are you doing that?" And he said, "Well, I want to make sure that blood is flowing through your legs and your feet, in a pretty nice and efficient way." And I'm like, "Okay, well, that makes sense to me." So again, those are the two that we're actually going to use in lab. So we want to do that really to assess circulatory efficiency. And another reason you'd want to do it, which is a little bit kind of a little bit more serious or dark or bleak, but if you're ever out in public or hopefully never in a position at home, but if you find somebody unresponsive, you want to be able to check their pulse and assess signs of life. And if you don't get a pulse, obviously you want to call 911 as quickly as possible and get help to that person as quickly as you can. All right, so let's see. Okay, venous return. We mentioned that blood coming back to the heart needs a little bit of assistance because, like we saw in that one graphic, pressure in the venous system is fairly low. So we have what's called venous return, which is the amount of blood getting back to the heart, and we need a little bit of help. And so there's a couple of things that help that. A couple of, I'm doing the air quotes, a couple of pumps called the muscular pump and the respiratory pump. So our skeletal muscles are very well vascularized, very rich blood supply. And so as skeletal muscles contract and relax, they again, here we see quotes, and I'm doing air quotes off camera. When skeletal muscles contract and relax, they milk or they pump blood, directing it back towards the heart. And this respiratory pump kind of does the same thing, but it's not direct contraction of muscles. We do have muscles in our bodies, which we'll talk about in the final unit, the diaphragm and external intercostal muscles. But what this respiratory pump is talking about is whenever we breathe, whenever we inhale and we exhale, there are pressure changes in our thoracic cavity, in our chest. And those pressure changes are going to, again, kind of milk or guide blood back towards the heart. Now, as blood is moving back to the heart from these two pumps, if you remember from anatomy, one of the main modifications, anatomical modifications of veins is the presence of valves. So let me go to this and you can see veins have valves. And so if blood, like indicated by these arrows, is going back up towards the heart and it goes past a valve, the valve will shut, especially if muscles are contracting. And if the valves are shut, it prevents blood from going inferior and pooling back down to our lower extremities. And it keeps moving past valves moving upward and upward till it gets back to the heart. So valves help ensure that blood in the venous system only goes one way, back towards the heart. And then we have what's called sympathetic vasoconstriction. There is a difference between vaso, V-A-S-O, constriction, and veno, V-E-N-O, constriction. Venoconstriction, kind of like the name implies, the sound of the name, venoconstriction is when the body, through the influence of the sympathetic nervous system, can send sympathetic impulses to our vasculature. And what it does, the more sympathetic impulses we get, it will cause the smooth muscle in veins to actually constrict. And that will increase pressure in them and help keep driving that blood back towards the heart. So vaso, V-A-S-O constriction is when our arteries constrict, but venoconstriction is when veins constrict. So make sure you remember that difference. Both are dealing with smooth muscle constricting, but veno is generally going to be talking about veins, and in context, kind of referring to one of the factors that aids in blood getting back towards the heart. Okay, now on to the major task at hand, which is talking about blood pressure. So blood pressure, huge deal, huge deal. Okay, so three main factors involved in regulating blood pressure: cardiac output, peripheral resistance, or oftentimes we will just say resistance, and then blood volume. Now, because we just did a whole video on cardiac output, I'm not going to go in depth and talk about it here, okay? But what I will say is that there is a direct relationship between cardiac output and blood pressure, meaning that if cardiac output goes up, then blood pressure goes up. So you have to think about then the factors that change cardiac output, which, if you remember, are heart rate and stroke volume. So if we start connecting the dots, okay, anything that increases heart rate or anything that increases stroke volume will increase cardiac output and therefore increase blood pressure. So again, if we go a little bit deeper, if you remember, the things that affected stroke volume were preload and contractility, okay? And I'm not going to mention afterload, but preload and contractility, okay? So then you, again, connecting the dots, you can say that if contractility increases, blood pressure increases. Or if preload increases, blood pressure increases. If they decrease, so if there's a decrease in contractility, then there will be a corresponding decrease in blood pressure. So that's what I mean when I say a direct relationship. Okay, so you have to start expanding your mind, and that sounds kind of hippie. You have to expand how you think about these different variables and be able to link them together, okay? So anything that changes cardiac output will change blood pressure, whether it's increasing it or decreasing it. So we're going to, like I said, we're not going to spend much time in this video talking about that because we already did in the third lecture video. So we're going to focus more on factors that affect resistance and blood volume. All right, so resistance or peripheral resistance, you will hear also called TPR, total peripheral resistance. I believe in my third lecture video, when I encouraged you guys to watch that other video that was in my video, kind of sounding like a matrix sort of thing here, but that nurse that was talking about cardiac output, she mentioned and called it total peripheral resistance, or TPR. So what is resistance? Okay, resistance, the opposition to flow. Okay, let's even change the color here to make it nice and fancy and fun. Let's just leave it bold and let's go blue. All right, so resistance. What is it? The opposition to flow. Or how easy is it, or how difficult is it for blood to flow through our vessels? So if blood has an easier time flowing through our vessels, there's less resisting it, less restricting the flow of blood, So we would say that resistance is lower. If blood is having a more difficult time flowing through the vessel, we would say resistance is higher. So opposing the flow of blood, making it more difficult for blood to flow through vessels, that's what resistance is. And like it says here, it's measurement of amount of friction encountered, amount of friction blood encounters with vessel walls, generally in peripheral circulation, in our systemic circulation. Okay, so when blood comes in contact with the walls of the vessel, there's more friction, because when blood is flowing through a vessel, a normal healthy vessel, there's some minor differences in how the blood flows through. The blood that's right against the walls of the vessel is flowing just a little bit slower than the blood flowing through the middle of the lumen, or the hollow part of the vessel itself. And the reason that we find that is because the blood flow closer to the walls of the vessel has a little bit more resistance, a little bit more friction, because the blood is physically coming in contact with the walls of the vessel. So it's not flowing as easy as the fluid or the blood right next to it that's in the middle of the vessel. So resistance, the opposition to flow. Now there's three important sources of resistance: blood viscosity, total blood vessel length, and blood vessel diameter. So we need to break those down real quick and talk about them. So first is blood viscosity, or how thick blood is. Okay, so blood viscosity, how thick the blood actually is. Let's go orange on this one. All right, blood viscosity, the thickness or stickiness of the blood, perhaps because of formed elements, platelets, or other factors in the blood, proteins in the blood. But here's the thing, and this one's pretty easy to kind of grasp. If the blood is thicker, then the viscosity will increase. And if the blood is thicker, if viscosity is higher, then resistance is higher, because it's harder for thicker or stickier blood to move through the vessel. Now, like they mentioned here, formed elements or plasma proteins, a couple of things that could actually increase the viscosity. There's something called the hematocrit. Let me actually put that over here. I can type it in for you. Can increase resistance. All right, now, what is the hematocrit? Okay, the hematocrit is the percentage of red blood cells in the blood itself. So if there's more red blood cells in our blood, it makes the blood thicker, which would then make it harder for it to flow through, and that would increase viscosity and therefore resistance. So, for example, how would we manipulate this? One way is by spending time at higher altitudes. If let's say if you go and you move from the valley and you move up to let's say you go out of state and you go to Colorado. Okay, you go to Denver. The Mile High City. Okay, or even higher than that. Let's say, and you move there. At first, the higher up in altitude you go, there's less oxygen in the air, and so to compensate for that, one thing that the body can actually do is produce more red blood cells. And in that time, if the body is producing more red blood cells to take advantage of hemoglobin and oxygen transport, that's going to temporarily increase the viscosity of the blood until your body adapts. And so that could, again, increase blood viscosity. So increasing the hematocrit increases viscosity, increases resistance, increases pressure. Or let's say you get severely dehydrated. Okay, part of our blood is plasma, the fluid portion, and if you get severely dehydrated, that can actually be decreased as well. And so if you decrease the volume of fluid in the blood, then the blood becomes thicker in terms of the elements that are still there. So even dehydration could increase viscosity. And if you increase viscosity, you increase resistance. You increase resistance, you increase pressure. So those are just a couple of ways that you might actually increase viscosity. Okay. Smoking and tobacco use can actually increase viscosity as well, because of increasing the amount of platelets that are in the blood. So kind of a bad thing overall is tobacco use. All right, blood vessel length. Okay, let's kind of change that one there, and let's you know what? Let's go a nice little happy bright shade of green there. All right, so blood vessel length. The longer the vessel, the greater the resistance encountered. So the further that blood has to travel through a blood vessel, the blood comes in greater contact with the vessel walls. That's going to increase the friction in the blood, which is increasing resistance. So the harder, again, the longer that blood has to travel over a greater distance, that increases friction, increases the amount of resistance that blood has to overcome to move through the vessels, and therefore pressure has to increase just to circulate the blood over a longer distance. Now, one of the more common ways for this is one of the factors. Viscosity, you can't change it as quickly as other factors, and blood vessel length, you can't change it as rapidly as other factors. So these two kind of take time to manipulate. One of the ways that, or probably one of the more common ways that blood vessel length is manipulated is through growth. As we age, as we go from childhood to adolescence, from adolescence to adulthood, our bodies increase in size, in physical mass. And so as we increase in physical mass, obviously our blood vessels have to increase in length for blood to circulate over a larger area. So the heart has to pump harder to get that blood out over a longer distance. Now, when we're adults, and I like to say, if we stop growing vertically, unfortunately, some of us, like myself, we have a tendency to grow horizontally, okay, or get more full-bodied, like a good wine, I'll say, full-bodied. Okay, so if percent body fat increases, okay, if you put on weight, let's just be real. Okay, if you put on weight, you get bigger, obviously. And if the body gets bigger, if the amount of body fat increases, fat is tissue. Fat needs a blood supply. So if we increase in physical mass, okay, blood vessel length increases. Therefore, resistance will increase. And so that's one of the dangers of increased body fat and obesity, is the effect on the heart from having to work so hard to pump blood out over a longer distance. So if you have too much body fat and your doctor says, you know what, your blood pressure is too high, you need to lose weight. I mean, it's so much easier said than done, but it's so true. It's so true. So viscosity and length, again, are very important elements for resistance, but they don't change quickly. But blood vessel diameter, however, can change extremely rapidly. So blood vessel diameter is, well, how big the lumen of the blood vessel is. And so this one, like it says here in this first bullet point, has the greatest influence on resistance, because the body can actually manipulate this fairly quickly. Okay, so blood vessel diameter has, again, a very dramatic impact on peripheral resistance. And so think about it like this, okay? If the blood vessel diameter is smaller, okay, so if it's a smaller opening, blood is coming in more contact with the vessel walls, which is increasing resistance, and it's harder for blood to flow through a smaller opening. So it's an indirect relationship that we have here. If blood vessel diameter decreases, resistance goes up. Okay, so again, if blood vessel diameter decreases, meaning the blood vessel gets smaller, the opening, the lumen, gets smaller, then resistance goes up because more blood is coming in more contact with the vessel walls, and it's harder for the blood to flow through. The flip side is if blood vessel diameter increases, the opening gets larger, the lumen gets larger in diameter. And if that's the case, it's easier for blood to flow through, and resistance would decrease. So again, an inverse relationship. So as blood vessel diameter goes up, resistance goes down. So let's link this specific change together with blood pressure. All right, so if blood vessel diameter goes down, if it gets smaller, blood pressure goes up. If blood vessel diameter increases, if it gets larger, then blood pressure goes down. So it's an inverse or an indirect relationship. Okay? Now, again, that can change very, very rapidly. And mainly that rapid change is actually going to be from the sympathetic nervous system. And specifically what's called vaso. Remember, I just mentioned a little bit ago, vasoconstriction, VASO. So there's a spot in the medulla. When in our second cardiac lecture, we talked about the cardiac control centers in the medulla, the cardioacceleratory and cardioinhibitory centers that will affect heart rate. There's another cluster of neurons in the medulla called the vasomotor center, VASO, vasomotor center. And when impulses come from the vasomotor center, they are sympathetic in nature. And when the vasomotor center increases the sympathetic stimulation throughout the body to blood vessels, that's going to cause vasoconstriction. Okay, so the more sympathetic impulses we get to blood vessels, they constrict. When the vasomotor center backs off its level of impulses sent out to our blood vessels, okay, they actually get larger, vasodilation. Okay, so vasoconstriction is associated with more sympathetic stimulation. Vasodilation is associated with less sympathetic stimulation. So the autonomic nervous system, okay, this is an autonomic function, sympathetic and parasympathetic. Okay, but this one is exclusively sympathetic. I just mentioned parasympathetic because I want you guys to remember, those subdivisions of the autonomic nervous system. Okay, but again, sympathetic only, okay, is what we're dealing with here whenever we talk about blood vessel diameter changes. And so again, the autonomic nervous system has the greatest impact on short-term regulation of blood vessel diameter and therefore blood pressure. Okay, now we're moving on. This is, as you can see, slide 17 of 29. All right, now let's talk about the factors that affect blood pressure. So we're looking at short-term regulation, basically, which is what I just mentioned. So the neural controls, we're looking at other things like hormonal or chemical controls. All of these things can have a moment-by-moment impact. And then the kidneys can actually get involved with long-term regulation of blood pressure. All right, so I just mentioned this, so I don't need to spend a whole lot of time talking about it. But remember, the cardiac control centers are in the medulla. And remember, we talked about these the other day. Okay, the cardioinhibitory and cardioacceleratory affecting heart rate. But this is the one I just mentioned, the vasomotor center. Okay, so vasomotor impulses, those sympathetic impulses, when they increase, we get vasoconstriction. When they decrease, we get vasodilation. So the point that I really want you to get here is that the autonomic nervous system can have a very rapid and a very dramatic impact on blood pressure simply by changing the degree of impulses sent from this center directly to the brain. Okay, so to the blood vessels. So let's just kind of change that, and let's go a different green there. Okay, so the vasomotor center, sympathetic impulses, like we have right here. Okay, now there's something that we need to address related. That involves the vasomotor center, and this is called the baroreceptor reflex. So we've talked about reflexes in the neuro unit, in our very first unit. And if you remember, we did our really fun reflex lab where we did reaction time testing and the patellar reflex and all that fun stuff. This is a reflex that we can't recreate in a lab. But this is a short-term neural mechanism. It's a reflex initiated by the central nervous system for the central nervous system to influence blood pressure when it changes moment by moment throughout the course of the day. So you typically don't feel when this is happening, but you can, you'll know if something changes pretty dramatically. Okay, so uh, the baroreceptor reflex. First of all, what are baroreceptors? Baroreceptors are effectively pressure sensors that we have in different areas of the body. In the neck with the carotid sinuses, the aortic arch, some of the larger arteries around the neck in the thorax. We have these pressure sensors that detect changes in arterial blood pressure. And when arterial blood pressure gets too high or starts to go too low, it initiates this reflex that will kind of be this link between our vascular system and the nervous system. And then the nervous system will initiate a response that will either so if our blood pressure drops, okay, MAP drops like it says here, or not. I'm not focusing on the high part, but when MAP changes, okay, so when our blood pressure changes, MAP changes accordingly, right? So if blood pressure drops, MAP drops. If blood pressure goes up, MAP goes up. So what I want you to focus in on here, though, is kind of just like this overarching concept that if blood pressure changes, whether it drops or whether it goes too high, that's going to initiate a specific baroreceptor reflex that will then reverse whatever the stimulus was. So if our blood pressure drops rapidly, that's going to initiate a baroreceptor reflex that will raise blood pressure. If our blood pressure all of a sudden spikes, that's going to initiate a different baroreceptor reflex that will then lower blood pressure back down to a normal range. So whether your blood pressure goes up or down, it's going to initiate this reflex that will then help return our blood pressure back to a normal, safe range. So we're going to look at two different baroreceptor reflexes. So this one right here is the baroreceptor reflex for rising blood pressure. All right, so here is our stimulus. Blood pressure goes up, and don't focus on, oh, Rogers, how did it go up? It's completely irrelevant. Okay, for us, all we need to know is that the blood pressure went up, so it goes up for some reason. Now the baroreceptors are going to be excited, they're going to be stimulated, and they're going to send impulses to the brain. So blood pressure goes up, and the baroreceptors are like, bro, they're talking to each other, bro, blood pressure went up. Or what does my son say, bruh? My Gen Z teenagers are like, bruh. I'm like, don't call me bruh. I'm dad, for heaven's sake. So baroreceptors, they can say bro. So they start talking to each other. They get excited. They start sending more impulses to the brain. Okay, so an increased number of impulses from the baroreceptors. They are going to stimulate the cardiac control centers in the brain, which we've already talked about. So look at what happens as a result of this stimulation coming from the baroreceptors. So I want you to focus on three parts here up in this one little area. All right. So number one, what does it tell us? It tells us that it stimulates the cardioinhibitory center. Number two, it inhibits the cardioacceleratory center. And then number three, it inhibits the vasomotor center. Okay, so let's quickly take those three individually. So stimulating the cardioinhibitory center, that's going to cause more parasympathetic impulses to go to the heart, which is going to lower the heart rate. Inhibiting the cardioacceleratory center means fewer sympathetic impulses to the heart to lower the heart rate and actually decrease contractility as well. And then if we inhibit, number three here, if we inhibit the vasomotor center, that's fewer sympathetic impulses to the smooth muscle and the blood vessels. All right, so if you take those three things into account, we can then see the physiological response right here. So over here, so a decrease in sympathetic impulses to the heart, okay? So like they say, heart rate is going to go down. Contractility is going to go down because with fewer sympathetic impulses, there's going to be less epinephrine involved, less calcium getting into the myocardium, so it's not going to contract with as much force. So heart rate goes down, contractility goes down, and cardiac output goes down. And remember, if any of those changes alone happens, blood pressure goes down, because remember that link between cardiac output and blood pressure. So all of those things happen together. And then over here, because of the inhibition of the vasomotor center, we get fewer sympathetic impulses to the blood vessels. And guess what? They dilate, vasodilation, like it shows us right here. And that makes resistance go down. All right, so again, let's just kind of recap here. Fewer sympathetic impulses, heart rate's going to go down, contractility is going to go down, cardiac output goes down. We get vasodilation, causing a decrease in resistance. All of that combined, okay, all of that combined is going to lower blood pressure back down to a normal range. Okay, so what set this whole thing into motion? Our blood pressure went up for some reason. Maybe you show up to class the week before the final and I say, you know what, I'm going to go on vacation, so we're going to take the final right now on right now tonight. And you're like, oh, holy crap, Rogers, that sucks. You're an a-hole, okay, for doing this to us. Yeah, that's a pretty douchey move. So, but just relax. I'm not going to do that to you guys. Okay, but if I did something like that, something crazy and mean, it's going to freak you out and you're going to stress out and your blood pressure is going to go up really quickly. And then what's going to happen is this whole reflex is going to get set into motion, and then your body's going to naturally lower your blood pressure, even though you're still going to be mad at me and probably not shower me with all the gifts that you're going to bring me during the night of the final. At least your blood pressure will go back down. Okay, so the baroreceptor reflex for rising blood pressure. The stimulus was blood pressure went up for some reason, and again, it doesn't matter what it is, it just goes up. But the response is that blood pressure goes down. So immediately, whatever the stimulus is, the outcome is going to be just the opposite. And so what you guys have to do is just kind of figure out what happens in between. Okay? Now let's look at the other side of this coin. So the stimulus was falling blood pressure. And, sometimes this can happen, like if you're sitting down for a long period of time or laying down and then you rapidly get up, you kind of experience this transient drop in blood pressure. Sometimes it can occur when women are pregnant. And if they're pregnant, and again, if they're sitting down for a longer period of time and they rapidly get up for some reason, they can experience a rapid and unsafe drop in blood pressure that could cause them to be lightheaded. If any of you ladies that have had children, if you've ever experienced that, this is kind of what we're looking at right here. So if the stimulus is falling blood pressure, okay, so that's our stimulus. What happens? All right. Well, the baroreceptors that detect changes in pressure, unlike the one we just talked about, when pressure goes up, they get excited. But as we can see, if the stimulus here is falling blood pressure, the baroreceptors are inhibited. They're not going to send as much or as many impulses to the brain. So they get inhibited, and they're like, bro, silence, bro. They're not communicating as much. They're inhibited. They're going to send fewer impulses to the brain. Okay, so fewer impulses from the baroreceptors because they're inhibited, fewer impulses to the brain. Look at the response. Okay, number one, it activates or it stimulates the cardioacceleratory center. Number two, it inhibits the cardioinhibitory center. And then number three, it stimulates the vasomotor center. So let's look at that again. So it stimulates the acceleratory center, inhibits the inhibitory center, and stimulates the vasomotor center. So when we look at those three things specifically that they list here, what we're saying now is that we're going to get more impulses to the heart that are sympathetic in nature from the cardioacceleratory center. And what happens when we get impulses from the cardioacceleratory center and the vasomotor center? Look at right here. Sympathetic impulses to the heart go up. Epinephrine is now involved because that's what is liberated by the sympathetic cardiac nerves. So heart rate goes up. Contractility goes up because that epinephrine is now facilitating more calcium getting into the myocardial cells. All right. And then cardiac output goes up. So all of those things increase. And then look at this one. Okay, when we get more impulses from the vasomotor center, that causes vasoconstriction. Blood vessel diameter decreases. Now look, resistance goes up. So you take all of these changes into account. Any one by themselves is going to raise blood pressure, but when they all work collectively, BP goes back up into a safe normal range. Okay, so the baroreceptor reflexes for rising and falling blood pressure. Short-term neural mechanisms. Now, chemical controls are also very short-term, but they do have a pretty substantial impact, whether they're hormones or other types of chemicals. Epinephrine, norepinephrine. Okay, we've talked about those. Okay, they cause vasoconstriction. They are sympathetic hormones. And they also, so not only do they cause vasoconstriction, but they increase heart rate. So epinephrine and norepinephrine are very powerful hormones that affect our heart. They increase heart rate and they increase contractility, which is going to increase, both of those changes are going to increase blood pressure. Okay, so and remember, we associate oftentimes those with stress, and not just like fight or flight kind of a stress, but when you're just under stress in general, the stress of life, work stress, relationship stress, or if you're a Dodgers fan, stress because you know that the Dodgers are going to choke in the playoffs. Yes, if you're watching this video, it's kind of in October, and I'm anticipating the Dodgers choking in the playoffs, and I'm hoping that because I'm a Giants fan and I hate the Dodgers. Anyway, these are, I think it's easy for us to associate them with stress as stress-related hormones. So it could be good stress, like maybe athletic stress, but when you're just under stress in general, there's more of these hormones circulating through our system, and they could have a pretty substantial impact on your heart. Angiotensin 2 is a chemical. Actually, we're going to talk about that more in just a few minutes, and I'll talk about it more when we get to the kidney material. But angiotensin 2 is a very powerful vasoconstrictor. And so if vasoconstriction occurs, that's going to cause resistance to go up and pressure to go up. ADH stands for antidiuretic hormone, is a vasoconstrictor as well. So again, anything, epinephrine, norepinephrine, angiotensin 2, ADH, any chemical in our body that functions as a vasoconstrictor is going to make blood pressure goes up because it increases resistance. Okay? Atrial natriuretic peptide, or ANP. Now, ANP is an interesting hormone. It comes from the heart itself, from the atria. And we're going to talk a little bit more about this in the kidney material. But ANP actually causes us to eliminate excess water. And when that happens, our blood volume actually goes down. Okay? And, oh, you know what? I don't think I mentioned blood volume. Let me just double check here. Yeah, I'll mention blood volume. Let me just kind of finish my train of thought here, and then I'll get to it, because cardiac output, resistance, and blood volume are the three main factors that affect pressure. So ANP actually it causes us to eliminate excess fluid. Okay. Now, actually, you know what? Let me focus in on blood volume for just a minute, because let me just make sure. I want to make sure you guys are getting accurate information. So if we go back up here, cardiac output, resistance, and blood volume. Yeah, I didn't talk about blood volume yet. It's kind of generally towards the end when I talk about that. But now that we're here, okay, let me mention this. All right, so blood volume, and you know what? Let me let's see. Let's actually add, because I don't think I have it over here. Yeah, let's do this. I'm gonna make a quarterback call at the line of scrimmage here. We're gonna add a new slide. All right, so let's call this one blood volume. All right, so let's connect the dots here. All right, atrial natriuretic peptide, or ANP, causes a hormone that causes us to eliminate excess fluid. And if we do that, if we, let's say, and you'll see that with an increase in urine output, you're going to lose water, and a decrease in blood volume actually has an impact on blood pressure. All right, so what is blood volume? Pretty much the amount of blood in the vasculature at any given time. Okay, sorry, 8 at any given time. All right, so the amount of blood in our body at any given time. So that the sheer physical presence of blood in our body, in our blood vessels at any given moment, is blood volume. And there is a direct relationship between blood volume and blood pressure. If there's more blood in the vessels, blood volume goes up. Therefore, pressure goes up. If blood volume goes down, then blood pressure goes down. And there are factors that can manipulate blood volume, like ANP is one of them. Okay, so when we experience changes with the amount of water in our bodies, we change blood volume. Okay, so because remember, part of our blood is actually water, and so there's different ways that blood volume can be manipulated. So let's say you hemorrhage. Something happens, you're injured, you lose blood, whether you bleed out and blood is out, like say you cut your hand pretty badly and you're bleeding out everywhere. Okay, you lose blood volume because there's not as much in your system. Okay, so let's say you hemorrhage, or a more pleasant way to lose blood is to give blood. When you donate blood, okay, your blood volume goes down. And so you temporarily experience a drop in blood volume and your blood pressure goes down. Let's say you're taking diuretics for some reason, because sometimes there are diuretics in blood pressure medications, or you're taking them because you want to lose weight. But if you take a diuretic, that increases your urinary output, and if you lose water, you lose blood volume and your blood pressure drops. Maybe even excessive sweating, like in the hotter months here in the valley, if you spend any time outside and you work outside and you sweat a lot, you lose water and your blood volume goes down. So things like that. So let's say bleeding, okay? Bleeding or increased urinary output, okay? Or excessive sweating, okay? We decrease blood volume. I'm just going to call it BV, okay? And up here, if you're wondering why I did that, you probably were told by an English instructor at some point, if you're going to use abbreviations, at some point you have to, the first time you do it, you have to do it like this, right? Where you spell it out and then do it. And then every time after it, you can just say that. All right. I used to get in trouble for that when I would write papers until it finally clicked for me. All right. So bleeding, whether that's you're hemorrhaging or maybe giving blood. Okay. Or here, let's add that too. Okay. So anything that's going to compromise your blood volume will lower blood pressure. Okay, excessive decrease blood volume and BP, blood pressure. All right. How would we increase blood volume? Let's say water intake. Drinking water. Okay. You drink water, you increase blood volume. Or administering IV fluid. If you get IV fluids at a hospital or in an ambulance, that's going to promote or put water in your body. It's going to increase blood volume. Let's say increased salt intake. Okay, maybe from going to Panda Express and eating some Chinese food, or eating a bunch of French fries, or eating potato chips. Eating anything high in salt is going to cause your body to hold on to water. Okay, so if you increase your salt intake, you're going to increase your blood volume because your body holds on to water, and that's going to raise your blood pressure. All right, so those are just a small sample of things that will manipulate blood volume. Okay, and when you manipulate blood volume, it automatically increases or decreases blood pressure. So it's kind of an important factor, a very important factor. Okay, so drinking water, administering IV fluids, and will increase BV and BP. Boom, there you go. All right, so there you go with blood volume. All right, I'm surprised I didn't have that in there already. Okay, just a couple more things here, because these are all things that are going to manipulate, or some of them are going to manipulate blood volume. Okay, so chemicals, short-term regulation of blood pressure. Nitric oxide. Okay, nitric oxide is a vasodilator, generally associated with histamine. You know, during the allergic response, histamine production will cause nitric oxide production and release in our bodies, and nitric oxide causes our blood vessels to vasodilate. Now, remember, vasodilation decreases resistance, and it's going to lower blood pressure. And you find nitric oxide quite a bit these days. Probably, I would say maybe over, at least that I've noticed it over the last maybe 25 years or so, with pre-workout supplements like C4. You can find that in Costco, Walmart, Target. It's a pretty popular pre-workout supplement. I've used it before, but you have to be very careful with that, because when you use pre-workout supplements like C4 or anything else that's out there in the market that you can get, like I said, Target, Walmart, GNC, supplements like that, when they cause vasodilation, they're going to increase blood flow to your musculature. So you'll hear people say, "Oh yeah, I can feel the increase in, the pump, and I feel like I have a more efficient workout." And it's partially true, but you've got to be careful especially with supplements like that are vasodilators, because if you're already sensitive to things like that, or maybe you don't even know. But let's say you have blood pressure issues, and if you take a supplement that has nitric oxide in it, it could cause an unsafe drop in blood pressure. Not to mention the itch. If any of you know what I'm talking about that have used supplements like that before, they cause you get this itchy feeling kind of all over your body, and it's a really weird sensation. But it's very real. I'm not advocating that you go down to Walmart and grab some C4 and take a scoop of it before you work out. If you're going to use supplements like that, it's always safe to consult your doctor first, or if you're not going to consult your doctor, for heaven's sake, don't take the full supplement dosage. Cut it in half at least until you figure out how your body is going to respond to it. Okay. Also, something with nitric oxide and vasodilation is, and you see it sometimes in TV commercials. And if you're going to work in healthcare, eventually you're probably going to work with patients that take erectile dysfunction drugs like Viagra, Cialis, Levitra, and all those prescription drugs. But any erectile dysfunction drug that is on the market, whether it's over the counter or prescription, is generally going to cause vasodilation to the vasculature of the penis to increase blood flow and achieve and maintain erections. But again, if you think about it in the context that we've been talking about, vasodilators, it's not just going to affect the genitals. It's going to affect the entire system. And so if you're a male that takes those medications, especially an older male, and if you remember ever seeing those commercials on television, um, they'll say, like, only take if if your heart is healthy enough for sex, because it could cause an unsafe drop in blood pressure as a vasodilator. And if your heart is already sensitive, that could potentially be a life-threatening situation. Okay, so nitric oxide is going to lower blood pressure. Alcohol. Okay, alcohol. You guys are never going to hear me say alcohol is bad, because I don't believe that. I'm actually going out of town tomorrow for the weekend, and we're going to do a little bit of, wife and I are going to do a little bit of wine tasting. But alcohol actually can drop blood pressure because, number one, it's a central nervous system depressant, so it could slow down information coming from the cardiac control centers. But in a more long-term effect, actually alcohol can act as a diuretic by inhibiting the secretion of ADH. ADH is a vasoconstrictor, and ADH also stimulates the kidneys to reabsorb water. So alcohol makes you pee, essentially. And if you pee a lot, you're losing water. Okay? So alcohol can actually lower blood pressure that way. All right, let's see. Summary of chemicals there. All right, now the kidneys oh crap, we're a little over an hour already. Time flies when you're having fun, doesn't it? Okay, so no, Rogers, this is not fun. Hurry up, wrap it up, and shut up. I get it. I hear you. All right, long-term mechanisms. So the kidneys. Now, the kidneys can have both a kind of, I guess we would say, a direct and indirect impact on blood pressure. The more rapid or direct effect is how the kidneys can manipulate blood or water volume, which is manipulating blood volume through eliminating water by making us urinate or holding on to it. So that's kind of a more of a rapid or a direct impact of kidney function and its relationship to blood pressure regulation, which I think is on the next slide. Okay, yeah, right there. But what we're going to focus on here is this: the more indirect way that the kidneys actually get involved. So something, and we'll look at this a little bit more in depth in the actual kidney unit, but there's something called the renin-angiotensin-aldosterone system. Now, this will, I don't really like using direct and indirect, but this can actually have a fairly rapid impact on blood pressure. But let's say I'm going to kind of get ahead of myself here. When in interactive phys, and we're going to use this probably in the lecture once we get to that portion of the class, they use a really good animation of a guy named Joaquin, and Joaquin's out surfing, and he's kind of sitting on his surfboard, and all of a sudden he's minding his own business, and I feel so bad for this guy every time I watch this little animation. So Joaquin's just enjoying the water, sitting on a surfboard, and then all of a sudden he gets attacked by a friggin' shark. And this shark bites his lower leg off. They don't actually show it, so you don't have to worry about that. So Joaquin gets attacked by a shark, poor guy, and gets taken to the hospital, and he loses a lot of blood, clearly, after a shark attack. And so when you lose blood, like we've been saying here, you lose blood volume because there's physically not as much blood in your body. And so when we experience a drop in blood pressure, specifically because of a drop in blood volume, this is one of the mechanisms in the body that kick in to help then raise blood volume and get blood pressure back up so that MAP can get back up as well. So the renin-angiotensin-aldosterone system, which we also abbreviate as the RAAS. Okay? The RAAS, the renin-angiotensin-aldosterone system. So a drop in blood pressure, okay, is going to have an impact on a specific structure in the nephrons of the kidneys called the afferent arterioles. And there are cells there that whenever we experience a drop in blood pressure, they're going to release the enzyme called renin. Okay, So the kidneys release an enzyme called renin. And in the bloodstream, renin is going to activate a protein called angiotensinogen. Okay? So renin, an enzyme, activates this protein called angiotensinogen and converts it into what's called angiotensin 1 right here. Now, angiotensin 1 will move through circulation, and as it passes through the pulmonary capillaries in the lungs, there's an enzyme, a membrane-bound enzyme in the pulmonary capillaries called angiotensin converting enzyme, or ACE. Okay, maybe you've heard of that before, ACE. So ACE, or angiotensin converting enzyme, like the name implies, it's pretty deep here, okay? ACE will convert angiotensin 1 into angiotensin 2. And like we've already mentioned, angiotensin 2 by itself is a vasoconstrictor. So it's going to make blood pressure go up alone that way. But that's not what we're focusing on here. Okay, angiotensin 2, okay, it's going to act different ways. Okay, well, we already mentioned this one. Okay, but these are the three main ways I wanted to focus in on right now that are going to affect blood volume. So angiotensin 2 is going to stimulate cells in the adrenal cortex to release a hormone called aldosterone. Okay, it's going to cause ADH to be released from the posterior pituitary. Now I'm going to address those in a second here. And then it's also going to activate our thirst center in the hypothalamus to kind of tell us, encourage us, order us to drink more water. Remember, if you drink more water, you boost blood volume. But let's get back to these real quick. Okay, so what do aldosterone and ADH do for blood volume? Well, let's summarize it. I'm just going to summarize it real quick. And when we get to the kidney material, we'll actually look at the locations and the specific cells that are involved. But aldosterone is going to stimulate the kidneys to reabsorb sodium. Okay, ADH is going to stimulate the kidneys to reabsorb water. And like we're going to see in that unit, water is chemically attracted to sodium. So if the kidneys are reabsorbing sodium because of the influence of aldosterone, they're also going to reabsorb water because of the influence of ADH. So wherever sodium goes, because of aldosterone, water will follow because of ADH. So if the kidneys reabsorb water, that increases blood volume. And if blood volume goes up, blood pressure goes up. Now, this isn't a super rapid response, but it will start working fairly quickly once this mechanism kicks in to help stimulate the body to reabsorb as much water as it possibly can. If you want to help it, you drink water, you give IV fluids. It's just going to help blood volume go up that much faster and help blood pressure stabilize. Okay, so these impacts aren't going to be as rapid as, let's say, neurological influence, because remember, neurological influence doesn't affect blood volume. That's more of a short-term mechanism, but this is going to affect blood volume directly. Okay, so the RAAS. And I think that's it, my friends. So we talked about a lot. We're at 1 hour and 8 minutes. That's crazy. I apologize, but if it was like that in class, hey, that's not bad. That's not bad at all. Okay. So as always, if you have questions, please write them down, and please don't hesitate to reach out and email them to me or hit me up during lab or come to my office and ask questions. And if you send questions via email or through Remind, just remember that I'll get back to you as quick as possible if it's during business hours. But if it's during the evenings or the weekends, you might get a little bit more of a delay in my reply. Okay? You guys take care, and I will see you next time when we start talking about the kidneys.